This program is brought to you by Emory University.
Good morning, everyone. Happy Friday. Our speaker this morning is Dr. Devinder Dhindsa. Devinder's a third-year fellow in the clinical investigator track, first-year clinical fellow. He did medical school at George Washington University, came here to Emory for residency, did preventive cardiology research during his 2 years of research. And as you can see, he's going to talk to us today about arrhythmic or malignant mitral valve prolapse. Devinder.
Sure. Thanks, Dr. Williams. Good morning, everyone. So sudden cardiac death is a rare but catastrophic complication of mitral valve prolapse. An arrhythmic mitral valve prolapse is an entity that's long been described in the literature, but only in the past few years has our ability to identify these high-risk patients really taken a step forward through extensive phenotyping of these individuals. So that's where I'll be spending a majority of my presentation. So next slide. So I have no relevant disclosures. My main learning objectives, as I discussed before, will be to assist the listener in identifying patients with mitral valve prolapse at high risk for sudden cardiac death, and then provide a basic understanding of the next steps in management of these high-risk individuals. So we'll start with a case. 20-year-old female with known mitral valve prolapse was complaining to her internist and general cardiologist of palpitations, dyspnea on exertion, and lightheadedness. Her cardiologist ordered a Holter monitor, which showed frequent premature ventricular contractions, close to 20,000 a day, and about 100 runs of non-sustained VT. She was subsequently referred to structural clinic, where she underwent an exercise treadmill test. She was only able to exercise about 8 minutes before she had to stop due to dyspnea, which is clearly abnormal for her age. This was her baseline EKG, which shows complex ventricular ectopy. You see multiple different morphologies of PVCs. You see PVCs in couplets. You see a right bundle morphology, and this is similar to what had been seen with her Holter monitor. She had a transthoracic echo as well. Here you see in the parasternal long axis views. You see thickened mitral valve leaflets. You do see bileaflet prolapse. Again, parasternal long axis view being the only view that you can diagnose mitral valve prolapse, and hard to quantitate the degree of mitral regurgitation in this video. Here's an en face view of the mitral valve, and again, you can appreciate the thickened leaflets. This is the parasternal short axis view. And again, some MR, but not a significant amount. She then went on to have a transesophageal echocardiogram, which is shown here. And our structural imagers and structural attendings did note some abnormalities here, namely in systole. You have this posterior curling of the mitral valve leaflet, and then you get a sense that there's a displacement of the insertion of the mitral valve leaflet to the left atrium from the LV attachment, which is termed mitral annular disjunction. And we'll talk more about that later, but that is certainly an important aspect to the pathophysiology of why these individuals are at risk for arrhythmia. So next, there was an X-plane view through the mitral valve such that you could see the structures in multiple different angles simultaneously. And what I want you to pay special attention to is this papillary muscle, and appreciate how much traction and stretch is placed on this muscle. Over time, this will cause fibrosis, which is key to development of a substrate for ventricular arrhythmia and sudden cardiac death in these patients. So again, we put color through the valve as well, and you see what was eventually called trace MR. So here's a 3D view of the valve, and again, you get an appreciation for how myxomatous the valve leaflets are. You get a sense of the prolapse in systole and the redundance of the leaflets. Again, trace MR through the valve. So she was then referred for an EP study, and on the first programmed ventricular stimulation, she had ventricular tachycardia that degenerated quickly to ventricular fibrillation. A primary prevention single-chamber ICD was subsequently placed. A heart team discussion was had with her and her family regarding her management, and she is planning on a mitral valve repair with cryoablation of the papillary muscles after the spring semester of school. So this was an example of a patient who was appropriately recognized to have high-risk features for sudden cardiac death, was subsequently risk stratified with an EP study, had a life-saving device placed, and has a plan for definitive correction of her structural issue. The issue being early identification of these patients is not always easy, and oftentimes their sentinel event is a cardiac arrest. An example that was in the news recently was Eleanor Barr. She was the wife of newly elected Kentucky Representative Andy Barr and a mother of two. She died suddenly at 39 years of age in her home office, and the coroner's report attributed her death to malignant mitral valve prolapse. So over the years, mitral valve prolapse has accrued several names: systolic click murmur syndrome, based on the characteristic physical exam findings; Barlow syndrome, in honor of John Barlow; billowing mitral cusp syndrome; myxomatous mitral valve syndrome; floppy valve syndrome, and redundant cuff syndrome. And you can get an appreciation on this autopsy specimen of how it earned some of these names. So regarding the history of mitral valve prolapse syndrome, Dr. DaCosta is given credit for initially describing the syndrome in Union soldiers during the Civil War. Again, he published several years after his experience in the Civil War. And this was similar to what had been described in British soldiers during the wars in Crimea in the 1850s. He describes symptoms of pain in the cardiac region, palpitation, headache, dimness of vision, and giddiness. And he writes of the physical exam findings: one of the cardiac sounds, the irregularity made it difficult to determine which, though I think it was the first, was curiously broken and sounded like the sudden motion of an only slightly elastic or cartilaginous substance. So DaCosta syndrome, or irritable heart, was rebranded as effort syndrome by Sir Thomas Lewis regarding his experience with British soldiers during World War I, who had symptoms of breathlessness, chest pain, and palpitations. And he wrote of the physical exam findings in these soldiers: an apical systolic murmur was present in 233 cases. In 208 of these, the murmur was not conducted. In the remaining 25, it was noted as loud and conducted to the axilla. And he writes of the epidemiology: the syndrome is not peculiarly a soldier's malady or an athlete's malady. It is one of the commonest chronic affections of sedentary town dwellers. So effort syndrome was further rebranded in the 20th century as neurocirculatory asthenia, or anxiety neurosis. It was a symptom, constellation of symptoms including palpitations, rapid heartbeat, chest pain, fatigue, anxiety, and dyspnea. Writing of the time: this disorder runs in families. Twice as many cases occur in women as compared with men. Patients were generally slight in body build and not well muscled. Systolic clicks identified through phonocardiography were found to be relatively common, and it occurred frequently in young subjects without evidence of heart disease, along with, quote, psychoneurosis, nervous people, and functional nervous disturbance, as well as accompanying palpitation and sudden stabbing precordial pain. Postural oscillatory changes and overall favorable prognosis were present. And this generally sums up our understanding of mitral valve prolapse syndrome today. However, what they were mistaken by was that the thought that these sounds and physical exam findings were extracardiac. They thought this was likely a neurologic or a psychiatric disorder. And it wasn't until Dr. John Barlow in the 1960s began publishing on this that we gained an understanding that this was actually an intracardiac phenomena, and that these physical exam findings were likely from the mitral valve. Here's a phonocardiogram which shows a systolic click and a late systolic murmur. And Dr. Barlow also described EKG abnormalities in these patients, namely T-wave inversions in leads 3 and AVF. And Dr. Barlow at that time did recognize a potential association between this mid-systolic click and sudden cardiac death. Here he describes a 39-year-old man with evidence of mitral valve prolapse who died suddenly while mowing his lawn. No cause of death was established at autopsy, nor was any coronary artery abnormality detected. A friend of his, Dr. B. Van Lingen, sent over some of the autopsy specimens. And here it shows what we would recognize today as a myxomatous posterior leaflet of the mitral valve, which was accidentally cut during the autopsy, but sewn back together. It wasn't until Dr. Michael Criley and his work with left ventricular syneangiography that we were able to visualize that these late systolic murmurs were associated with abnormal prolapse of the posterior mitral valve leaflet, and that the clicks were associated with pathologic changes in the chordae tendineae. So regarding the epidemiology of mitral valve prolapse, it's a common disorder affecting 1 to 3% of the general population, which in the United States works out to be about 7 to 8 million people. It has a widely variable prognosis in the literature, but generally recognized to have a benign course. Of note, it is the most common reason for severe mitral insufficiency requiring mitral valve surgery in the United States. It is a risk factor for endocarditis as well as heart failure, but where I want to spend the majority of the talk is the association with sudden cardiac death. So regarding the diagnosis of mitral valve prolapse, Dr. Thames teaches us this. In the parasternal long axis view, you draw a line through the mitral annulus. And if you see displacement of the one or both mitral valve leaflets greater than 2 millimeters above the plane of the annulus, then that is diagnostic of mitral valve prolapse. It was previously overdiagnosed in the apical four-chamber view because the mitral valve is saddle-shaped. Even non-disease valves can appear to prolapse in the apical four-chamber view, and there was a point in time that mitral valve prolapse was overdiagnosed, and the prevalence was thought to be almost 20%. That has been ameliorated with the latest diagnostic criteria, which is what I talked about here. And diffuse leaflet thickening greater than 5 millimeters supports the diagnosis, and these two features comprise what's termed classic mitral valve prolapse. So M mode can also be useful in the diagnosis of mitral valve prolapse, and here you see the mitral valve prolapsing into the left atrium, accompanied by late systolic mitral regurgitation. So regarding the etiologies of mitral valve prolapse, I want to spend the majority of the next two slides on myxomatous mitral valve prolapse and fibroelastic deficiency. I'll mention briefly here that connective tissue disorders, including Marfan syndrome, Ehlers-Danlos syndrome, pseudoxanthoma elasticum, Lees-Dyke syndrome, osteogenesis imperfecta, they all disrupt collagen, and they can disrupt the normal architecture of the mitral valve, leading to prolapse. But the two more important etiologies are myxomatous mitral valve syndrome and fibroelastic deficiency. Here you have a transesophageal echo image showing a thickened myxomatous mitral valve. Here are two pictures from the OR in which you get an appreciation for how the redundance of the leaflets and how thickened these valves are, and this is actually after a repair. So it's characterized by deposition of myxomatous material rich in mucopolysaccharides, primarily in the spongiosa layer of the valve. On electron microscopy, you would see disruption and fragmentation of collagen fibrils in the normal architecture. Both leaflets are involved in myxomatous mitral valve syndrome, and they become redundant and prolapse. There's billowing and systole and hooding. And an important point, the prolapse can be severe, but mitral regurgitation not. This is in contrast to fibroelastic deficiency. And here's again a transesophageal echocardiogram image here, along with two images from the OR. And what you see in fibroelastic deficiency, there's actually a lack of connective tissue as the pathologic mechanism, and this triggers leaflet and chordal thinning with eventual chordal rupture. These individuals do have mitral regurgitation, and it tends to present in men in the 5th and 6th decade of life. It's more localized. It only affects one valve, and it preferentially involves P2. So regarding the incidence of sudden cardiac death in mitral valve prolapse patients, This was a study done by Dr. Rick Nishimura, published in 1985, about 237 minimally symptomatic or asymptomatic patients with a history of mitral valve prolapse, and followed them for 6 years with an 88% survival probability, where we established that mitral valve prolapse generally does have a benign course. You see here in the dashed lines, it's supposed to represent the general population, the solid line representing the mitral valve prolapse cohort, and they were not statistically significantly different in terms of survival. However, when you look actually at the complications of individuals with mitral valve prolapse who did have complications, you see that sudden death occurred in 6 of the patients, which makes up about 2.5% of this cohort. Of the 6 patients who did die suddenly, 2 were women, 31 and 49 years of age, and the other 4 were men, age 55 and above. 3 of these patients had no prior history of cardiac disease or ventricular arrhythmia, but importantly, 3 did have previously documented asymptomatic complex ventricular ectopy, and 2 of those 3 were taking group 1 antiarrhythmic agents, and 1 was taking propranolol. So this is another cohort in Amsterdam in which they followed 300 patients with idiopathic mitral valve prolapse. There's a female predominance in this population with a mean age of 42. And again, they were followed for 6 years. And these were both symptomatic and asymptomatic mitral valve prolapse patients. Sudden cardiac death occurred in 3 out of the 300 patients. Among those patients, 1 was a 27-year-old man who actually initially presented with a VF arrest, was found to have mitral valve prolapse when he was successfully resuscitated and brought to the unit, was started on a beta blocker, had improvement on Holter monitor of his ventricular arrhythmia, and then went home and died a few months after the fact. 1 was a 53-year-old woman actually who had asymptomatic ventricular ectopy noted on an outpatient Holter monitor, and prior to being able to be started on medications, died suddenly. And the last patient that died in this cohort was a 70-year-old male with a history of heart failure, had a heart failure admission, went home, and died suddenly a few months after the fact. So how about in the young and healthy? There was a study of NCAA athletes from 2002 to 2011. There were 64 probable cardiovascular deaths in this cohort. Among those who had a confirmed cardiovascular death, mitral valve prolapse was one of the deaths was attributed to mitral valve prolapse in comparison to other etiologies that we think of in these athletes, including HOCM, coronary artery anomalies, and cardiomyopathies. So how about in the community? In the Oregon Sudden Unexpected Death Study, there were 729 sudden cardiac arrest cases that were evaluated over a 12-year period. It was an older cohort with a male predominance. Mitral valve prolapse was seen in 17 cases prior to arrest. And compared to cases without mitral valve prolapse, those individuals with sudden cardiac arrest and mitral valve prolapse were younger with fewer cardiovascular risk factors or known coronary disease. And although this isn't necessarily attributing their sudden cardiac arrest to mitral valve or arrhythmic mitral valve prolapse, these individuals had fewer risk factors for more common etiologies of cardiac arrest. The Mayo Clinic actually has an idiopathic out-of-hospital cardiac arrest clinic from which they enrolled 24 patients in a study, 16 women with a median age of 33.5 years. They all had secondary prevention ICDs placed and had extensive workup, which was negative for ischemia, cardiomyopathy, or channelopathies. Bileaflet mitral valve prolapse was identified in 10 of these patients. An important point, 9 out of the 10 had mild to moderate MR, only 1 individual had severe MR. And when they looked at all the variables that they had in the study, only bileaflet mitral valve prolapse was associated with ventricular arrhythmias requiring ICD therapy on follow-up with an odds ratio of nearly 7. And again, when you compare non-diseased valves to those with mitral valve prolapse, the mitral valve prolapse patients had a higher burden of ventricular bigeminy, VT, and PVCs of alternating morphologies. So when you look at the incidence of sudden cardiac death for mitral valve prolapse, it's much lower than hypertrophic cardiomyopathy. It is higher than the general adult population. When you look at the total number of individuals at risk, just because of the large number of mitral valve prolapse syndrome patients, there is a similar number of patients at risk to hypertrophic cardiomyopathy. The issue is similar to the general adult population. You have a heterogeneous population of very low risk individuals, which mitral valve prolapse by and large is a very low risk condition, but you do have these high risk individuals scattered throughout this population with a similar phenotype. And so there's a challenge of identifying this small number of high risk patients that are concealed within a very large population of low risk patients. No single risk factor has proven to be a consistent predictor of sudden cardiac death in this population, but I will present several findings on echo, EKG, and MRI that have been associated with increased risk of sudden cardiac death in this population. So I'll just talk through some of the TTE findings and go in more detail in the following slides. The Piccolo sign, bileaflet involvement, mitral regurgitation, systolic curling, which we got an appreciation for in the prior TE images, and mitral annular disjunction. So the Piccolo sign, it's quantified using lateral mitral annular velocities with Doppler tissue imaging. This is something we get on all of our complete TTEs in our echo labs, but rather than focusing on diastole, actually we're looking in systole for the Piccolo sign, and it's defined as a peak systolic mitral annulus velocity of greater than 16 centimeters per second. It's a marker of abrupt, forceful myocardial stretch, and it's so named because of its distinctive appearance, similar to that of the Piccolo seen on Prussian soldiers' helmets. And in the 21 patient sample, those with the Piccolo sign were more likely to have ventricular arrhythmia and late gadolinium enhancement on cardiac MRI as compared to those who did not have a positive Piccolo sign. So mitral regurgitation, in an observational series of 58 patients, moderate to severe mitral regurgitation was an independent predictor of ventricular arrhythmia. However, mitral valve prolapse related to sudden cardiac death is known to occur in patients without severe MR. And this is actually work done by Dr. Dollar while he was at the NIH. There was a case series of 15 patients with sudden cardiac death and autopsy-proven mitral valve prolapse. 3 had a prior echo or LV angio. 1 patient had trace MR, 1 with no MR, and 1 with only moderate MR. So again, mitral regurgitation is not necessary for individuals to have sudden cardiac arrest from arrhythmic mitral valve prolapse. So mitral annular disjunction, I'm showing you a cartoon and a TTE image. It's defined as the spatial displacement of the point of insertion of the posterior mitral valve leaflet, which accounts for a separation between the left atrial wall and mitral valve junction and the left ventricular attachment in systole. And again, you get an appreciation for that in systole. See the aortic valve is open here. It was initially introduced to describe the autopsy findings of a patient with a long history of mitral valve prolapse, palpitations, who did have a sudden cardiac arrest event. So you see on cardiac MR, A and C represent control hearts, and B and D are from a patient with arrhythmic mitral valve prolapse. You see the normal anatomy where the mitral valve annulus does not have any separation from the LV attachment. You see here in the individual with arrhythmic mitral valve prolapse, there is a spatial displacement of the point of insertion during systole. And you see on histology, again, normal anatomy and spatial displacement. And this blue staining here represents fibrosis. This is a process that does, over time, lead to fibrosis in the affected areas. So there were 36 patients with arrhythmic mitral valve prolapse with late gadolinium enhancement on MRI, and 16 patients without late gadolinium enhancement on MRI that were enrolled in a study. And mitral annular disjunction, mitral annular diameter, and prevalence of posterior systolic curling, which I'll show you in the next slide, were higher in mitral valve prolapse patients with scar on cardiac MR than in those without. So systolic curling, I'll show you, refers to this unusual curling of the posterior valve leaflet on the adjacent myocardium. And again, this is highly associated with mitral annular disjunction. There are again markers of laxity of the mitral annulus. You see a Spearman's correlation coefficient of 0.85, so highly correlated with other markers that are associated with scar on MRI. There's also several characteristic EKG findings. Greater than 75% of mitral valve prolapse patients with sudden cardiac death have biphasic or inverted T waves in the inferior leads, as you can see here. However, as described by Dr. Barlow, this is also seen in 40% of all mitral valve prolapse patients. PVCs are actually common in this population. However, complex PVCs, complex ventricular ectopy, PVCs occurring in couplets, VT on Holter monitoring is a cause for concern. And here, as we showed you with our patient, there's a right bundle morphology with a superior axis. In this patient, again, right bundle morphology with an inferior axis in this population. And these are high-risk features on Holter monitor. And down in D is an aborted sudden cardiac arrest. So on cardiac MRI, you do see in these areas where you do see significant amounts of myocardial stretch, namely the papillary muscles and the inferobasal LV fibrosis that is seen on MRI as late gadolinium enhancement. On histology, you see the blue staining. It does correspond to areas of fibrosis as well in the papillary muscle and adjacent myocardium. Again, represents subendocardial LV fibrosis in these characteristic areas, the papillary muscles, predominantly the posterior medial pap, and the infrabasal LV. So why do mitral valve prolapse patients develop fibrosis? As I've been hinting at, it's mostly stretch-induced and traction-induced fibrosis. Displacement of the mitral annular junction causes stress-induced fibrosis in that infrabasal wall. An excessive leaflet motion accounts for mechanical stretch of the infrabasal and papillary muscles, again, which leads to scarring, which is central to the pathogenesis of ventricular arrhythmias and central sudden cardiac death in this population. So this is a figure made by Dr. Mark Miller, one of the electrophysiologists at Mount Sinai, who has an interest in this, of several non-invasive markers associated with sudden cardiac death in mitral valve prolapse. And as we talked about, EKG findings of inferior T-wave inversions, complex ventricular ectopy on Holter monitoring or EKG, echo with these findings of spiked systolic high velocity signal, the Piccolo sign, also mitral annular disjunction and posterior curling, and then MRI findings of late gadolinium enhancement representing myocardial or papillary scar are all individuals that should be considered high risk for sudden cardiac death. This is an algorithm proposed by Dr. Basso in a review that was in circulation 2 years ago. Again, in individuals with echocardiographic diagnosis of classic mitral valve prolapse, defined as we talked about previously, the 2 millimeter displacement in the peristernal long axis view of one or both mitral valve leaflets and thickened valve leaflets. Individuals with presyncope or syncope, physical exam findings of mitral valve prolapse, characteristic EKG findings, as well as higher risk Holter findings, and then structural abnormalities, including mitral annular disjunction and systolic curling. These represent patients that should be risk stratified further, either with cardiac MR or EP study. Again, our experience at Emory has been to risk stratify these individuals with an EP study, as we saw in the prior patient. Now, there's really no guidance from our professional societies, ACC, AHA, ESC, or HRS regarding management of these patients. So we are mostly reliant on expert opinion, and what the experts would dictate, or what experts recommend, are at least a transthoracic echo in these patients. One, to quantify MR, but more specifically for individuals and their arrhythmic risk. You would look for evidence of mitral annular disjunction, systolic curling, or the Piccolo sign. Actually, a 7-day external Holter monitor as recommended to look for ventricular arrhythmias. And for patients with abnormal findings on either of these two, then a cardiac MR would be recommended. So regarding the role for ICDs and EP studies in these patients, ICDs are generally indicated for secondary prevention. Based on limited available evidence, it's reasonable to utilize EP studies to risk stratify patients. In those with a positive EP study, which is defined as sustained monomorphic VT induced with up to 3 ventricular extra stimuli, or polymorphic VT or VF induced with up to 2 ventricular stimuli, extra stimuli, placement of an ICD is recommended. If you don't have an EP study or it's negative in an otherwise high-risk patient, you can consider a long-term loop recorder. And again, additional studies are needed to understand the prognosticability of programmed electrical ventricular stimulation in this population. We do treat this as a scar-based VT, although it's not clear whether we're having false positives as a result of these studies. But this is our practice, and in the absence of evidence to the contrary, this is how we risk stratify patients. So regarding the role of catheter ablation in these patients, so again, most of our therapeutic studies in these patients, given the rarity of the disease, is mostly derived from case reports and case series. So in 14 patients with bileaflet mitral valve prolapse who underwent a catheter ablation, there was a high rate of acute procedural success in terminating the arrhythmia that the individuals were brought to the lab for, with a reduction in ICD therapies. However, 6 of the 14, nearly half of them, had to come back for a repeat ablation, and they found a new left ventricular focus in 5 out of the 6. So late recurrence can arise from sites not targeted at initial ablation, and this is because you have not addressed the underlying structural issue that's causing ongoing traction and stretch on the myocardium and the papillary muscles that is leading to ongoing fibrosis and scar. Mitral valve surgery theoretically should relieve stretch on these papillary muscles. Again, this is a case series from the Mayo Clinic in which there were patients who had sudden cardiac arrest and were successfully resuscitated. They all had secondary prevention ICDs. And data was actually available for 5 years, ICD data, 5 years prior to the mitral valve surgery and 6 years after the surgical intervention. Actually, mitral valve repair was associated with a reduction in VT, VF, and ICD therapies. And it was actually nearly a 10-fold reduction after surgery. Cryoablation of the papillary muscles is reasonable and has been described in case reports. And here's a cartoon, as well as a photo from one such case report in which the surgeon is introducing a basket catheter through a right atriotomy, going through the mitral valve, and cryoablating the papillary muscles. And that's actually also been our practice at Emory. So I did want to share a case of a patient who did have mitral valve surgery and did also have arrhythmic mitral valve prolapse. So he's a 32-year-old male with a history of exercise-induced ventricular tachycardia. He's older now, but at the time of his surgery, he was 32. He had a secondary prevention ICD placed, which was subsequently explanted because of an infection. He had a subcutaneous ICD placed after that, which again got infected and so had to be explanted. And so he was very hesitant to have another device placed. Here was his echo at the time, and you can gain an appreciation for some of the findings that we talked about before. namely bileaflet mitral valve prolapse, a redundance of the valves, very thick valves, and you have a sense of mitral annular disjunction as well as this posterior systolic curling. Now, he ended up having a mitral valve repair, actually due to progressive MR. He had a resection of the P2 scallop. He had a cleft closure of P1 and P2, and he had a 35 millimeter annuloplasty band placed. And here's his post-surgical result. And you can actually gain an appreciation for how improved the stretch on the papillary muscles is now. So on M mode, this is his M mode prior to his mitral valve surgery. You see significant prolapse into the left atrium that has been corrected now surgically. You see a very nice example of the Piccolo sign where his systolic velocity through the lateral mitral annulus was at least 21 centimeters per second, greater than the 16 centimeters per second that is used to diagnose the Piccolo sign. Again, that has been corrected due to the surgery. So interestingly for him, after the mitral valve surgery, he did have an EP study to determine his risk of recurrent arrhythmia, and his VT was non-inducible actually in the lab. So he was actually determined to be low risk and now no longer has a device, or as we believe, does not need a device. So in conclusion, there is a recognizable subset of patients with mitral valve prolapse that develop major complications. Expert guidance would recommend a Holter monitor to look for complex ventricular arrhythmias, echocardiogram to look for the Piccolo sign, mitral annular disjunction, systolic curling, and bileaflet prolapse, and consideration of an MRI to assess for scar. And there is a need for a risk score that is prospectively studied to determine risk in these patients. Again, there's a lack of evidence due to the rarity of the disease and our ability to recognize this population. And as we identify more patients, our evidence will improve. So special thanks to Dr. Jokadar for reviewing the slides and giving useful feedback, and Dr. Lode for first introducing me to this topic when he was actually taking care of this patient while I was on EP in July. So I'll take any questions now. Thanks for your attention.
Thanks, Devinder. Good review of this topic. You sort of beat me to the punch there with your last. I'm glad you said that at the end of your conclusions, that you're right. It does seem that it's a little bit, there can be some degree of guesswork. Obviously, if you have a patient who's having a lot of symptomatic ventricular ectopy / arrhythmias or frank syncope, you know, they sort of come in with a flashing sign over their head. They might be high risk in someone with mitral valve prolapse, but right. So I guess the trick is identifying these patients before they become symptomatic, who might become, you know, who might be sort of a smoldering high risk patient. Back when I was growing up, when I was a kid, there was some sense that the degree of mitral regurgitation might, in these patients, might have a correlation. But I think it was the Mayo data you mentioned that in those smaller studies that did not seem to bear out. Did you see, what are your thoughts on the actual degree of mitral regurgitation, whether that can be a predictor?
So mitral regurgitation, especially severe mitral regurgitation, is an independent predictor of ventricular arrhythmias. Although some of the data I showed you was that it's not necessary for sudden cardiac arrest in these patients. And actually, several of these patients had very mild or moderate MR. So it doesn't identify these patients who have a different etiology for their arrest, which mainly being that stretch and traction leading to fibrosis. It's kind of a separate issue than the mitral regurgitation.
Sure. Other questions from the group?
I enjoyed that very much. This is Spencer.
Yes, sir.
I didn't get on the very beginning of your presentation and so I don't know if you mentioned this, but there's an Emory reference about this subject. Goes way back to the early 70s. Woody Cobbs, who was here, used to examine the hearts at autopsy, and he developed a hypothesis that the ventricle, which looked hyperkinetic, really wasn't. That was not the problem. And Michael Criley at the time had advocated the idea that there's somehow a hyperdynamic ventricle caused the pap muscles to come up and the valve to prolapse. This is before echo, so we studied this in the cath lab, and I was able to identify a coronary artery going up into the papillary muscle. So you could see that during violent mitral valve prolapse, the papillary muscle actually extended up into the toward the mitral valve annulus, and it looked like so you could document that the papillary muscle was not contracting; it was being stretched, and so we had a number of patients with ventricular arrhythmias, and at that time, mitral valve replacement was done for some of these cases. And when you did mitral valve replacement, particularly if you cut the chordal attachments, you ended up with little aneurysmal segments where it looked like hypercontractility. But there's a reference. I'll send these two references to you. One
that'd be great. Yeah.
One is 74 from the American Heart Meeting, and then a publication later from Cobbs and myself. So send me your email address.
Yes, sir. We'll do.
The easiest one is sking01 at Emory, sking01 at emory.edu. And
Yes,
I'll
sir.
send you this. Actually, I've got a copy of this, so I'll send you this reference so you can add it to your historic information.
Oh, that'd be great. Appreciate it.
Yeah. In fact, Cobbs went down because of that publication. John Barlow asked him to come to South Africa and present this stuff. And, Barlow had described this and Crowley had described, but Crowley used the term prolapse. Barlow
Yes,
never used the term prolapse. So Crowley's prolapse got to be the name of the thing.
Right. Yes, sir.
It's great. Thanks, Dr. King.
Yeah, Devinder, this is Patrick. I was going to ask you a similar question in that in the Mayo series that you presented, were all of those patients, did they all undergo repair, or were any of those replacements? Because from time to time you will see some of these patients that will have undergone repair, and there's so much redundancy in the leaflets, but
Right.
they continue to have some degree of prolapse, and you wonder if that's actually resolved the issue, or if there's still that tension on the papillary muscles, and maybe a replacement is what you need to do.
Right. So in this series, it was a repair, and there was some resection of some of the redundant parts of the mitral valve leaflets.
Okay.
Actually, interestingly, so the first two of those patients, they did the repair because of severe MR. And then the last three in that series, it was actually because of arrhythmia. And their experience up to the first two showed that it did lead to dramatic reduction in ventricular arrhythmia. So that's another neat thing that I didn't bring up in the presentation.
Yeah. My sense is that a lot of the cardiac surgeons approach this problem, unless they've come in with, an arrest, the same way that they approach like unroofing of a coronary bridge. There's many of them that are very uneasy about this and whether or not it's going to, make a significant difference. That's just my experience. I don't know if others have similar experience.
All right. Well, if there are no other questions, I want to thank Devinder for his talk and thank everyone for being here this morning. And we'll see everybody next Friday. Thank you.
The preceding program is copyrighted by Emory University.